Hey, I'm Alyssa Kimble, and we're going to be talking about POCUS in the era of COVID-19. So our objectives today, we're going to talk about a little bit of the history of ultrasound during a pandemic, review COVID-19 disease findings, which will help us direct our findings, and then discuss diagnostic approach and POCUS utility, review some scanning techniques, and then review POCUS applications in lung, cardiac, and briefly liver exam. So interestingly, when I was researching this topic, I found out that using POCUS in a pandemic was not a new idea. All the way back in 2009, they started using POCUS to scan patients. There was a cross-sectional study that I found where they took symptomatic patients who had a normal chest X-ray, but were suspected to have influenza. And they found that 15 out of the 16 patients had abnormal patterns of an interstitial syndrome. Subsequently, 63% of them were diagnosed with a viral pneumonia, influenza H1N1. 38% were diagnosed with a bacterial pneumonia. They found that lung ultrasound was 94% sensitive and 89% specific for abnormal lung findings. And it actually outperformed chest X-ray in symptomatic patients. Again, POCUS was used in the avian influenza H7N9, and in subsequent flu in 2013, 14, and 16. And in all of these times, they found specific findings on ultrasound for viral pneumonia. And so they found that POCUS was helpful in the detection of early pneumonia by looking for things like B lines, pleural effusions, subpleural consolidations, and this pattern will kind of come up again. So in general, COVID-19, as we all know, has a variable degree of presentation. So people can be asymptomatic, have mild pneumonia, ARDS. Because they have limited mobility and they're thrombogenic, they can form DVTs or PEs. We've seen cases of myocarditis, stress-induced cardiomyopathy, epicardial versus microvascular coronary thrombi, pericardial effusions, and then acute hepatitis. So this is how we're going to direct our ultrasound evaluation to see some of these findings. So in regards to diagnosis, interestingly, CT is actually more sensitive than viral PCR. However, the gold standard for diagnosing COVID is to use PCR at this time. Ultrasound can really be helpful as a guide for monitoring and management. It can aid as a screening tool, but it's not used alone for diagnosis in itself. And then interestingly, it said they don't really recommend people who are trying to master the skill of POCUS to perform it at the bedside, mostly because of the time that it takes to scan patients. People who may be unfamiliar with POCUS may be spending longer time to be exposed, and they're trying to limit exposure to patient time just for risk of infection. So some of the advantages of POCUS in COVID, you can evaluate the heart and lung, which sometimes can be difficult to auscultate because of the vent or prone positioning. You can identify worsening pulmonary or cardiac disease at the bedside. It may help reduce exposure to staff, patients, or other personnel by avoiding transport throughout the hospital. And then the decrease of radiation exposure. So rather than going through repeat CTs every few days, you can check at the bedside with POCUS and see if there's any improvement. Some of the disadvantages are operator inexperience, inability to convert to a full exam. So for example, if you're doing a cardiac exam and you want to do further windows, it can sometimes be limited, and then potentially having missed findings. So for the lung exam, they recommend a minimum of 12 points on the lung exam. This is because COVID is such a patchy infiltration. So if you can see in the top of the lung, so the top anterior portion of the lung, there may be on the CT scan very minimal lung disease, where if you look out more lateral, you can see that there's a lot of infiltration in that lung, a lot of ground glass opacity. So depending on where you're putting that ultrasound, you may see more normal tissue versus really impaired lung. That's why it's important to check all 12 fields. So if you look at our gentleman over here, you'll see our 6 points on each side, leading to a total 12-point lung exam. They recommend 2 points in the front of the lung, 3 medially, and 2 in the posterior lungs. As you see here, we have sometimes patients who are affected by COVID but are still somewhat mobile. We recommend these positions, so either an upright position, a lateral decubitus, or a supine position to scan. Unfortunately, as COVID does affect patients very seriously, we often see that patients are intubated. And what we know from our studies is that placing them prone can help increase aeration, which can sometimes make it difficult to scan patients. So the article actually talked about putting someone in what we call a swimmer's position. So elevating the arm above the head, placing a towel under the inside of the arm in order to elevate that thorax so that you can check both the anterior lungs and then as they're laying prone, continue to the posterior lungs. So this is just a general progression of what we're going to see, and we're about to look at images. So normal lung, you have the two ribs with posterior shadowing and then A-lines. Really what we start to see with COVID is B-lines first. That's really the most sensitive thing that we're going to talk about you see with COVID. And then eventually you can start to see consolidation of these B-lines and interruptions of the pleura. And then eventually you can see air bronchograms, consolidation. Sometimes you can see a little bit of a pleural effusion as well. Just to make a note, this transition through the lungs is not always unidirectional, and it's not always showing progression or severity. It's sort of a general trend that we do see with patients though. So these are the ultrasound. So here, this is a great review of the ultrasound we've done this week. First, we see some B lines coming down. We have a pleural line here with some B lines. Here we have some confluent B lines. You'll start to see them sort of merge together, kind of making this waterfall-like sign. Here we have an irregular and thickened pleura, some subpleural consolidations, so right here, and then dynamic air bronchograms. So you may wonder, well, how sensitive is it if we're doing ultrasound to evaluate COVID? So there was a study that was performed early in the pandemic, March 3rd to 30th in Beijing Hospital, where they took patients who had a positive PCR test. They stratified them into duration of symptoms, so early, intermediate, or late, early being defined as less than 20 days, intermediate 20 to 30, and late greater than 30. And they evaluated what were the lung ultrasound findings and how common were they seen in patients who were diagnosed with COVID-19. Interestingly, despite the duration of symptoms, all patients were found to have B lines. So patients in early, intermediate, and late all had B lines. They did note that thickened pleural lines were more commonly seen in late disease as compared to early. This is thought to be secondary to the more pulmonary fibrosis that patients develop after the acute inflammation. And then they also classified the patients by moderate to severe disease. Mild was excluded because mild was typically patients who were not admitted to the hospital. And they found that patients with severe disease were more likely to have pulmonary consolidations. So this was another retrospective cohort that had 93 patients suspected with COVID. They had them undergo all three tests, PCR, CT, and bedside ultrasound on admission. The ultrasound was performed via the Blue protocol, and they were deemed the test to be positive if they found B lines in one or more areas on the protocol. Both the CT evaluations and the POCUS evaluations were analyzed by researchers that were blinded to all three test results. And what they found is that POCUS was quite sensitive and had a good negative predictive value, but it wasn't very specific. And so this research team was proposing that POCUS may be able to be used in part of the diagnostic screening as a tool to help determine if patients may or may not have some signs of COVID, and that if there was an absence of B lines, that there was a good chance that they may not have COVID. And then comparing CT to lung ultrasound. So in the beginning, we talked about how CT is actually one of the most sensitive tools that we can use to start seeing early changes of COVID. So there was a research study, a little bit of a smaller population, 26 patients, and it was an observational study. But they wanted to find out how sensitive was lung ultrasound compared to CT. So patients got a CT and a lung ultrasound on the day of admission. each test, so the CT and the lung ultrasound, underwent their own scoring system. So CT scoring was done based on the extension and distribution of ground glass opacities and consolidations. And the lung ultrasound underwent a scoring system, which was recommended by Sotaldi, which looked at the presence, distribution, and severity of the following. So if they had B lines, if they had subpleural consolidations, broken pleural lines, white lung consolidations. And each of these were given a score. So this is the Sotaldi recommended scoring method by Sotaldi. So I'm just going to go through those 3 scores and give you a couple of examples on the right of what these lung findings look like. So Sotaldi scoring 0, the pleural line, as you see here, is continuous and regular. There's no disruptions in the pleural line, and we see these beautiful A lines reverberating down. And this is the curvilinear probe. Again, you see the pleural line and the A lines reverberating down. In a Sotaldi scoring system, a number 1 is when we start to see indentations of the pleural line. So you see the pleural line here, and you see sort of these notches in the pleural line with a little bit of hyperacoustic enhancement behind. A number 2 is when the pleural line is disrupted or broken. And you can see consolidations behind the pleural line. So again, here we see these disruptions of the pleural line with some consolidations. And then finally, a 3, we see densely large extended white lung and consolidations. And then at the end of this, so they scanned patients in actually 14 different locations. And at the end, the highest score in each quadrant was then used, and all numbers were summed for a total overall score. So Sotaldi actually recommended using a 14-point lung exam, particularly because it was the most thorough in regards to evaluating all areas of the lung. Again, because COVID is such a patchy disease, it's easy to miss small infiltrates in areas. So these are the 14 points, similar to the 6 points, just with 2 additional spots. And so what they found, in general, these were the most common findings, were just more pictures, B lines, subpleural microconsolidations, consolidations with air bronchograms. Overall, what they found is that every person had B lines, whether it was distinct B lines versus confluent B lines. All the patients had some form of B lines on ultrasound. And all the patients had bilateral involvement. These are just some of the general CT finding signs that you can find when they did their scoring. And so they took the findings and the scores from both the CT scoring system and compared it to the lung ultrasound scoring system, and found that the correlation coefficient was 0.065 with a p-value less than 0.001. So there is a moderate correlation between lung ultrasound findings and CT findings. They also then took the lung ultrasound scoring system and plotted it with oxygen saturation on room air and found a negative correlation coefficient. So worsening lung ultrasound findings led to higher oxygen requirements. So that was a little bit about lung. I wanted to just talk briefly about cardiac exam and what they recommend. So the American Society of Echocardiography recommends for patients with POCUS this protocol. So going through sort of a limited view, but trying to cover several different areas. So performing parasternal long, parasternal short, apical, assessing the IVC, and then looking at the lung. So assessing for A lines, pleural effusions, B lines, and lung consolidation. And so in COVID, really what we're looking for are these findings. So we know that in COVID, patients can have a reduced ejection fraction secondary to myocarditis, stress-induced cardiomyopathy, or some kind of thrombi leading to cardiac wall damage. So in this first picture we see here, we have this patient with obvious reduced EF. I know we talked about the EPSS. You see very little mitral valve movement here. There's minimal cardiac shortening. And in general, you can see the heart has a very poor squeeze function. In COVID, you also see pericardial effusions and myocarditis. So here we see two examples. This is a large pericardial effusion with an anechoic fluid structure here surrounding the pericardium. Again, here you see a pericardial effusion with some evidence of tamponade. You can see this right ventricle collapse. And then finally, some of the things we look for are evidence of a PE with right heart strain. So here we have a short axis view. You can see the left ventricle is hyperdynamic, working very hard. This right ventricle here is very limited in movement. It's enlarged, and it has that positive D sign from strain. Here we see a 4-chamber view. We see a hyperkinetic apex with minimal movement of the right ventricular wall, indicative of McConnell sign. So another example of that right heart strain that you can see, likely from a pulmonary embolism leading to increased pressures. So the last thing I wanted to touch on was just evaluating the liver in patients with COVID-19. This isn't something that's necessarily standard, but I thought this was interesting. There was a retrospective cohort done in January to April in Germany, and they looked at patients who had a positive COVID test and evaluated and stratified them based on their transaminase level. So into normal transaminase, less than 10 times the upper limit normal, and then greater than 10 times the upper limit normal. They took the patients who had abnormal transaminases and then had them undergo ultrasound. And so what they found was a correlation. So there was only 1 out of 80 patients that required ICU level of care who did not have a transaminitis. In patients who had a transaminitis that was less than 10 times the upper limit normal, they saw that 28 out of those 39 patients, so about 70%, required ICU care. And then in the group of patients who had a transaminitis greater than 10 times the upper limit normal, all of them required ICU level care. Again, sort of in the bigger picture, more than likely patients who had significant elevated transaminitis to this level had some component of organ failure and potentially multi-organ failure requiring ICU stay. So there are some confounders to this, but it was interesting to see that trend. So on liver ultrasound, their most common findings, so that's on this chart over here, we see general findings that you can see in liver pathology and then in correlation with liver transaminitis level. So the most common finding was actually a thickened gallbladder wall. So that's what we're seeing up here. You see thickened gallbladder wall and then sludge. So a little bit of sludge. It's a little hard to tell in this picture, but it's a little more hypoechoic. Those were the most common things that were seen in patients with elevated transaminase levels. Other things that people found were rounded liver angle, hepatomegaly. Here on this right side, it wasn't as common in patients, but I thought this was a great example of hepatitis. So you see more of a decreased echogenicity of the liver, and here they call this the starry sky appearance. You see that the bile ducts are very hyperechoic, sort of making these stars in the night sky surrounded by the liver. And then down here is a picture of a Doppler on the liver, and you see very poor vascularity. That was actually one of the findings in patients who had very severe transaminitis. So if you look here, not detectable hepatic artery, it was more commonly seen in patients with severe transaminases. And unfortunately, this patient died the same day, so it seems that it may be a poor prognostic factor. I thought this was a really interesting case just to kind of tell us and wrap up about the limitations in utility of POCUS. So here on the left, I see a fairly normal liver. This is actually, there was a patient that had persistent elevation of liver enzymes and GGT. The sonography looked relatively normal, but they did an MRCP which showed irregular bile ducts leading to the suspected diagnosis of secondary sclerosing cholangitis. And really the reason why I have this slide here is just to kind of remind us that POCUS can be a tool, but it's not necessarily to replace our clinical judgment. And it's not finding something that appears to be normal doesn't tell us the whole picture. So it can be an excellent bedside assessment tool, but really we need to use it in conjunction with our clinical assessment for patients. So in summary, bedside ultrasound can be a useful tool for the surveillance and management of POCUS, COVID. We recommend a minimum of 12-point lung examination due to the patchy-like distribution of the disease. The most sensitive marker for lung involvement is B lines, whether it be distinct or confluent B lines. You should always assess lung and cardiac function at baseline and then continue to monitor throughout hospital stay. And again, POCUS is not a replacement for your other clinical tools and cannot be used alone for clinical diagnosis. Thank you so much. And these are my resources.